We're going to look at the neuromuscular junction in the somatic nervous system. So the neuromuscular junction is just where the lower motor neuron is going to synapse with the muscle fiber or the muscle cell. So definitely know what the neuromuscular junction is. That's really important to know. And just a couple of terms here. We're going to change the name of the axon terminal to the terminal bouton. So we're no longer going to be calling the axon terminal that, we're going to call it the terminal bouton. And then on the skeletal muscle cell, we're going to call that cell membrane where it's synapsing with the terminal bouton from the lower motor neuron. We're going to call that the motor end plate. And that's where the nicotinic cholinergic receptors are going to be located that are going to bind to the neurotransmitter acetylcholine that's released from the terminal bouton. So let's just take a look at a picture here. So here's our lower motor neuron that is coming down, and here's the terminal bouton, no longer called an axon terminal. And here is our skeletal muscle cell below. And the cell membrane where it's all kind of folded up here, that's called the motor end plate. And the reason that it's all wrinkled like that is that will increase the surface area. And then you can pack more nicotinic cholinergic receptors onto that motor end plate. And if we take a close-up look here, you can see on this motor end plate we have the nicotinic cholinergic receptors located on the skeletal muscle cells. So when the acetylcholine is released from the terminal bouton from the somatic motor neuron, they will just diffuse across the synaptic cleft and then bind to the nicotinic cholinergic receptors that are on the skeletal muscle cell. So let's just take a look at what happens at this neuromuscular junction. I've got everything written down here, but I think it'll be easier if we just take a look at a picture. All right, so we've got the terminal bouton up here at the top from our lower motor neuron of our somatic motor neuron, and the action potential reaches the terminal bouton. That'll trigger the voltage-gated calcium channels to open. Calcium will come in, and that'll trigger the exocytosis of the neurotransmitter acetylcholine into the synaptic cleft. And then acetylcholine will just diffuse across and bind to the nicotinic cholinergic receptors that are located on this motor end plate that's part of the cell membrane of the skeletal muscle cell. And when acetylcholine binds to the nicotinic cholinergic receptors, remember these nicotinic cholinergic receptors are ionotropic receptors, so they're ligand-gated ion channels. So when acetylcholine binds, that triggers the gate to open, and mostly sodium will come into the cell. And when sodium comes into the skeletal muscle cell, that's going to cause the skeletal muscle cell to depolarize, and we're going to create a graded potential that now has a new name. So we're not going to call it a graded potential or an EPSP. We're going to call this graded potential an end plate potential. And the reason we call it that is because we're at the motor end plate, and that's just what they chose to call it. So it is a graded potential that's depolarizing, and they just call it an end plate potential. And sometimes you'll see it abbreviated as EPP. All right, so why are these end plate potentials, these graded potentials, so important? Well, these sodium ions that are coming in are going to flow both directions through this skeletal muscle cell. And what we have located on either side of this motor end plate are some voltage-gated sodium channels and voltage-gated potassium channels. And so we're going to reach threshold with our end plate potential, And that'll trigger the opening of these voltage-gated sodium and voltage-gated potassium channels. And that's going to stimulate the production of an action potential in our skeletal muscle cell here. So we actually trigger an action potential in our skeletal muscle cell, and that'll travel across the membrane of the skeletal muscle cell, and that will actually trigger the skeletal muscle cell to contract. And we'll see how that happens in the next chapter. All right, so the last thing that needs to happen is once we've gotten our response, we've caused our skeletal muscle cell to contract, we usually don't want it to keep contracting. So we need to get rid of our neurotransmitter acetylcholine. So how we do that is we've got that enzyme, acetylcholinesterase, which is just located right in the synaptic cleft, and it will just chew up the acetylcholine and get rid of it very quickly. And then that will stop the response and stop the contraction. All right, so just a couple of examples here of some things that affect the neuromuscular junction in skeletal muscle. One is an autoimmune disease called myasthenia gravis. This is not very common, but we do see some people that develop this. And what happens is the immune system decides that it no longer likes the nicotinic cholinergic receptors on your skeletal muscle cells, and so your immune system forms antibodies to attack them and destroy them. So this disease is called myasthenia gravis, and if you take a look at the name, Maya is referring to muscle, asthenia refers to weakness, gravis means heavy. So myasthenia gravis just describes that you end up with these heavy, weak muscles. And you can see in this picture of this man with myasthenia gravis, if you notice one of his eyelids is drooping. Okay, so if you decrease the number of nicotinic cholinergic receptors, what's going to happen? So hopefully that you thought about this and you realize that you're not going to be able to let as much sodium into the skeletal muscle cell. You're not going to create as big of an end plate potential. You're not going to reach threshold. And you won't produce an action potential in the skeletal muscle cell, and so you're not going to trigger contraction. And so what happens in myasthenia gravis is that your muscle cells can't contract. And so they get really weak and heavy. It affects your facial and throat muscles first. So you get these droopy eyelids, you have trouble swallowing and eating, and then it can move on and affect your limbs and then eventually your diaphragm as well and cause problems with breathing. So it can be pretty serious. So this is just a picture of what happens in myasthenia gravis. So up on the top, we've got a normal scenario. Here's the terminal bouton of our lower motor neuron from our somatic nervous system. And here's our skeletal muscle cell with the motor end plate here. Here's a close-up on the right, and you can see all of the nicotinic cholinergic receptors. So this is how many we should have. But on the bottom is somebody with myasthenia gravis. So their immune system has produced these antibodies that has destroyed some of the nicotinic cholinergic receptors on the skeletal muscle cell. And so you can see that they have a lot less nicotinic cholinergic receptors than normal. So when the acetylcholine is released and binds to the few nicotinic cholinergic receptors that are left and let sodium ions in, you're not going to be able to create as big of an end plate potential. So up here, where you have a normal amount of nicotinic cholinergic receptors, your end plate potential maybe would be this big. But down here, where you have a lot less nicotinic cholinergic receptors, maybe your end plate potential is only that big. Okay, and so with the smaller end plate potential, you don't reach threshold, you're not going to trigger an action potential, and then you're not able to contract your muscles. So they're basically paralyzed. How they treat this, you don't need to know this, but they can actually remove the antibodies from the blood, and then they also will give a drug that will block acetylcholinesterase. Because if you can leave acetylcholine around longer and not chew it up so quickly, then the acetylcholine can bind repeatedly to the few nicotinic cholinergic receptors that are left and keep opening them, and then letting more and more sodium ions in, and then creating a bigger end plate potential. So it gets big enough that you reach threshold, and then you can trigger an action potential and then contract the muscle. Okay, and then just another thing that affects the neuromuscular junction. This is something called curare, and this is a poison that's found in a plant in South America. And the Native Americans down there discovered this, that if they took the the stems and the leaves, and they crushed it up, the curare was in the sap from the plant, and they put that onto their arrows and they would go hunting. And so when they would shoot an animal, the curare would get into the animal's circulation and it would paralyze the animal, so they wouldn't be able to contract their muscles, and then they wouldn't be able to run away anymore, and that would allow the hunters to catch up to them very quickly. So what curare does is it competes with acetylcholine to bind to the nicotinic cholinergic receptors. And if the curare gets there first, it will bind and prevent the acetylcholine from binding. And if acetylcholine can't bind, then you're not going to be able to contract your muscles. So we do have some drugs that are derivatives of curare. They're called neuromuscular blocking agents. And we do use this in general anesthesia. So they'll give this to the person once they're unconscious, and this will paralyze their muscles and allow the person to be intubated a lot easier, because the gag reflex is pretty strong, and so you want to paralyze those muscles so you can get the endotracheal tube in. So if you've ever had general anesthesia, you've been given one of these neuromuscular blocking agents. You were just unconscious when they gave it to you, so you didn't realize that you've had this. If they gave it to you while you were still conscious, you would be paralyzed, and you could feel everything they were doing, but you couldn't move or talk or do anything about what they were doing, and you could feel pain and everything. So it's not a drug that you could do surgery with. All right, so this is table 11.4 from your book. This one I would spend some time studying. This one is really good. It has the autonomic nervous system, both parasympathetic and sympathetic divisions, and the somatic nervous system, and just compares them. What I would do is maybe just take this table and recreate it, leave these three columns on the right here blank, and try to fill them in and see if you can do that. So like the origin, remember parasympathetic, remember we call that craniosacral. And then remember sympathetic, we call that thoracolumbar. And the somatic nervous system, remember that lower motor neuron is coming from that ventral horn of the spinal cord, whereas the autonomic preganglionic neuron is coming from the lateral horn. And then another big difference, we've got two neurons going from the central nervous system out to the target organ in the autonomic nervous system, and we only have one in the somatic nervous system. what they're targeting is very different. So I would know that. I would also know what neurotransmitters they're using. Okay. And then also know what receptor the neurotransmitter is binding to. And then also know if they're under involuntary or voluntary control. Okay. So I would spend some time on this and practice, recreating this and leaving things blank and see if you can fill this in without looking at your notes. That would be a good way to study this.